طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله تعالى وبركاته. الضيوف الكرام، البروفيسورز، كل الحضور، الطلبة، كل الناس المهتمين بالمايستوما، يتكبدوا المشاغ وجو من تركوا أعمالهم وجو الكونفرنس. appreciate يعني حاجة دي. I'm Ihab Abdul Aziz. I'm presenting a cytokine profile of stimulated blood monocytes of mycetoma patient. As you know, mycetoma is a major mycological problem in Sudan characterized by high recurrent rate and poor treatment outcome. Madurilla mycetomatis is a commonest cause of black-green mycetoma in Sudan. This is a triad of diagnosis of clinical diagnosis of mycetoma. It is paleless subcutaneous masses with discharging sinuses. The disease may spread to involve the skin and deep structure, resulting in massive destruction of the bone, causing deformity, and then may end with amputation. Immunity to mycetoma. This tumor has an underlying major immunological reaction which till now is not fully understood. There is few reports about the immune response to mycetoma to explain the disease pathogenesis and clinical variations. However, partial impairment of the cell-mediated immunity response in patients severely infected or not responding to medical treatment. This is did by Professor Mahjoub. Also, Professor Hassan did a tissue reaction histopathology and immunohistochemistry, described triple-layer tissue reaction zones, inner zone containing neutrophils, an intermediate zone containing mainly macrophage, and outer zone containing mainly lymphocytes and plasma cells. Also, in the histopathology and histochemistry, immunohistochemistry, they detected high level of IgM and IgA and complement identified in the grains of actinomycetoma. IL-10 and IL-4 Th2 cytokines detected on the immunohistochemistry of mycetoma lesions, while interferon gamma did not detect it. High level of IgM were detected in the serum of mycetoma patients due to Madurilla mycetomatis, whereas low level of IgA were detected. The cytokines or lymphokines are a small hormone-like polypeptide that have pleiotropic biological activity in several cell types. Cytokines act as a chemical messenger that control immune responses. They are secreted by white cells, T cells, and epithelial cells, and some other cells. There are at least 17 different kinds of interleukins and 3 classes of interferon called alpha, beta, and gamma, and various subsets. There are 2 general grouping of cytokine, Th1 cytokine and Th2 cytokines. Th1 cytokines contain interferon gamma, which promote cellular mediated immunity, and Th2 and interleukin 10 is a Th2 cytokines induce humoral immunity. This is a major cytokine which involve and modulate the immune response delays the immune response. In mycological infection, in fungal infections, especially in the skin infection and subcutaneous infections, dendritic cells, it is the antigen presenting cells of this fungus products, which presents the antigen for T lymphocytes as in this graphs. Here we show the role of cytokines modulating the immune response to cellular and humoral immunity. Here in the Th1 cytokine, the major cytokine is interferon gamma, and which the The cutted line is indicating the inhibition of cytokine for the other types of immunity. Interferon gamma suppress the humoral immunity, and interleukin 10 suppress the cellular immunity. Objectives of our study. General objectives: to determine cytokine profiles of stimulated peripheral blood monocyte of EU mycetoma patients. Specific objections: to determine interferon gamma, interleukin 10, TGF-beta, and TNF-alpha profiles of different groups of EU mycetoma patients. Also to correlate the cytokine response with treatment of EU mycetoma patient, which is ketoconazole. Methodology. The study design. This is a cross-sectional hospital-based study conducted at Mycetoma Research Centers and Institute of Endemic Disease, University of Khartoum. Approval of this study was taken from the SOBA Ethical Committee and Institute of Endemic Disease. Our study concluded 48 individuals. 27 of them confirmed EU mycetoma patients. They are confirmed based on clinical presentations and fine needle aspiration and ultrasound imaging, and with or without MRI. Also include 21 negative controls. They are negative control from the same endemic area. They were co-patients that they were come with with those patients. We try to take female and male from both of them, but here the female, they are few in the endemic control because most of co-patients they are male. We group the patient according to clinical presentation and to the response to ketoconazole treatments. Those with clinical presentation: patient with massive lesion more than 10 centimeters, those are 10 patients, and patient with multiple lesions, those are 6 patients, and patient with EU mycetoma and co-infection with other chronic disease, and those are 5 patients. Also, according to the ketoconazole treatments, patients respond to ketoconazole, there are 11 patients, and those did not respond, there are 6 patients. We took blood sample from the Mycetoma Research Center, from the patient in the Mycetoma Research Centers, 5 to 10 ml venous blood from the participant. We collected in the heparinized tube, and then we isolated the peripheral. Immediately we process, after we collect the blood, immediately we process and start to isolate the white cells in form of mononuclear cells. We use Ficol hypophage gradients centrifuge. Then we test the cell for count and viability. Then we put it in the when we extract it in the PRM media, and then we put it in the wells, 24 wells, and every wells contain only 1 million cells. And then we added the Madurella mycetomatous antigens. These antigens is a culture filtrates antigens prepared in Mycetoma Research Center by the mycologist Dr. Abdullah Osman. Then incubated for 72 hours, and then we extract, and then we put it in a centrifugate, and we took the supernatant and we test the supernatant for the cytokines. We're using ELISA, sandwich ELISA. And then the data was analyzed by SPSS and Sigma plot for cytokines profiles. Result and discussion, same way. Most our patients and control are from the same endemic area. We are trying to matching the control and cases. Most of them are from Jazeera, and then Kordofan and Sinnar and White Niles. Also, they have the same occupations. Most of them are farmers. but here the student is low because most of the co-patients are almost older. Yeah. Also, as mycetoma, we know the foot is the most affected organs. This is the cytokine, and this is sigma block showing the cytokine profiles. As we show here, the control significant interferon gamma concentrations was highly detected in supernatant of stimulated peripheral blood of control group were compared with the patients. Here are the controls. If you compare the patient with control, it takes that the control is much interferon gamma rather than the patients. And then after compare interferon gamma concentrations with responder to treatment and non-responder to treatment, also no relations or no variation between those responder and not responder, no significant data. But still we show here obviously the control is much than detected much than the patients. Interleukin 10, also interleukin 10 here, the patients showed, especially the massive lesions, showed higher than the massive lesions, and the multiple lesions, they are higher than the controls. Here the controls, higher than the controls. This is concerning interleukin 2, as we said, Th2 cytokines, and interferon gamma is Th1 cytokines. Also, in compare with those treatment for medical treatment for ketoconazole and for ketoconazole responding to treatment and non-responding to treatment, as we show here, responder and non-responder, no variation between the responder and non-responder. But still the control in IL-10 is showing, is not detected in IL-10 in controls. TGF-beta, TGF-beta here, this cytokine, we show the distribution of this cytokine in all groups, no variations. Even in control, we detected the TGF-beta. TGF-beta is a regulatory cytokine secreted by regulatory cells called T17s and CD25, and these cytokines is used in control of the infection and organize the infection in the body, in the cellular immunity. So no significant data was detected in TGF-beta to correlate, is it higher or is it lower. Also in response to medical treatment, TGF-beta also showed no variation and no difference. Interestingly, TNF alpha cytokines was not detected in our plates in both those responder to medical treatment and non-responder, and in all cases we don't know if the TNF if we use other antigen rather than this antigen, it may induce this TNF, because TNF is a cytokine very important in growth of tumors and in regression of tumors. As we know, in high concentration may increase the tumor growth, and in moderate concentration it controls the growth of tumors. In conclusions, a high level of interferon gamma concentration produced by peripheral blood monocytes of control is likely to be associated with protection against mycetoma and may indicate subclinical infections. A high level of patients' interleukin 10 is associated with occurrence of the disease, and its concentration is related to disease severity. The fact that stimulated peripheral blood monocytes of mycetoma patients produce high interleukin cytokines and low interferon gamma suggests that The pathogenesis of EU mycetoma is mediated by Th2 CD4 positive cells. The 4 cytokines concentration level were not affected by response to medical treatment. So I think pre and post treatment should be assessed more for those patients. And here, just as a cross-sectional study, just we take those responding and those not responding. If we use responding, if we use pre-treatment and post-treatment, and we follow the patient as prospective study, it may indicate some changes in cytokine profiles. Our recommendations: similar study should be conducted in field in areas where mycetoma is endemic, and to compare with non-endemic areas, with non-endemic controls. It may be important to compare the cytokine profiles to the lesions, histopathology, appearance of in-depth to understanding of the immune response. The culture fit rates of the mycetoma, of the Madrella mycetoma, the antigen we used, showed a good result, therefore should be purified more to extract specific antigen that may be used in diagnostic test and vaccine production. My deep thanks for my supervisor, Professor Maawiya Mukhtar, and Professor Ahmed Hassan Fahal, and so Dr. Abdullah Usman, and Dr. Sahar Mubarak, and also my deep friend for Muhammad Usman in Institute of Endemic Disease, and my group in Institute of Endemic Disease, and my Mycetoma Research Center, and also my deep thanks for my group in National Control Program of Mycetoma, and for you for your attention. Thank you.
Thank you very much, Dr. Ihab. Clearly, this study is the thesis work of Dr. Ihab for his master's degree. And of course, he had a very short time and limited funds to do the work. That's why he was restricted to study patients in the hospital. And studies in patients in hospitals usually limit you to very few parameters that you can study, so that you can understand or you highlight the points you want to go further on. The importance of going from the lab to the field in this study is very clear, because he has indicated something which should be followed in the field. Of course, the co-patients are usually people that are very much related to the patients. They live in the same environment, and they may be exposed to the same conditions. So the possibility of having an infection is there. That's why we have to study the population in the villages and then compare that population to a non-endemic area of mycetoma. And of course, clearly we know that immunity to mycetoma infections lacks studies in many areas, and we have to concentrate on the indicators that we see in our small studies, and we have to concentrate on field work so as to verify further and understand the process of this disease. Now I open the discussion for anyone who wants to ask Dr. Ihab for... Okay. Maybe we can go to the second speaker, because they have very similar subjects, and she will tell us about the cytokines profiles in mycetoma also. Ms. Najwa Joda, and she is working with the mycetoma group at the center here.
Okay. Good morning, everybody. I would like to present my topic in cytokines profile in mycetoma patients. As you know, mycetoma is a chronic subcutaneous cutaneous infection, tissue, fascia, and caudally underlying bone. And mycetoma infection must be suspected when dealing of 3 clinical features: sinuses, swelling, and grains. The disease resulting from traumatic inoculation of causative agent, either to be eomycete or actinomycete, which is present in the soil. Mycetoma mycetomatis, it is the main etiological agent of mycetoma infection in Sudan. And for the actinomycete, it's Streptomyces somaliensis and Actinomydula maduri, Actinomydula bacteriae. It is the most causative agent in Sudan. Mycetoma, as you know, it is endemic in tropical and subtropical country, mainly in Sudan, Brazil, India. This is area share the same characteristic climatic conditions, which is characterized by cold conditions in the period from October to June, and rainy season from June to October. And this is the area of mycetoma in Sudan. The endemic distributions or geographical distributions of mycetoma in Sudan in Savannah region, which it is a transitional area between desert in the south and between desert in the north and forest in the south. This is area characteristic by sandy soil in the west of the Sudan, where the area of actinomycete, and clay soils in the middle of the Sudan, where is the area of eomycetoma. The common trees in this area, locally called nabak, tabaldi, haskanid, and hashab. And the most common grasses in this area, it is ushar. And this is the environmental occurrence of Mycetoma mycetomatis in the Sudan. Most people from mycetoma patients from Kawahla tribe from the west of the Sudan, middle of the Sudan, and Jawama from the Kordofan. The immune response to mycetoma infection, it is mediated by many factors, which fungus-related factors, host-related factors, environmental-related factors. Fungus-related factors include the melanin. This is easily characterized by windy and anahid and rugged soil wall. Secondly, the ability of this fungus to adapt mammal tissue indicates some ecological similarity between fungus environmental occurrence and living mammal tissue. That means fungus mycelia combine together to produce sclerotia, and this is demonstrated by Sarah Abdallah. Here, this is sclerotia or grains produced by Mycetoma mycetomatis in vitro. Then sclerotia, it is germinated and produce conidia or fungus mycelia. Here, this is fungus mycelia, conidia. Here we show this is abnormal structure, sac-like ascospore, or I don't know. And this is grains of Mycetoma mycetomatis in vitro. Host-related factors include mycetoma infections as other many mycosis infections controlled by neutrophils. And neutrophils, it is act as the first cell line defense against mycetoma infections. This act as phagocytic cells. Then after 2 to 3 days, monocyte came to the area of the infections. Neutrophils produce many cytokines to chemotact another neutrophils to the site of the infections. Neutrophils produce IL-8, which is demonstrated by Windy, and TNF beta, TNF alpha, which is the pro-inflammatory cytokines. This is cytokines produced by neutrophils response from the tissue damage. Another cells here, dendritic cells, which act as antigen-presenting cells, macrophage, have no roots in mycetoma infections. Langerhans act as phagocytic cells, take the antigen or conidia in the case of mycetoma, presenting the conidia for T helper cells, and this explains why all people in mycetoma endemic area produce high level of antibody in spite of no mycetoma infections appear in these people. This is Langerhans cells in the epidermis of normal tissue, which act the antigen, presenting the antigen to T lymphocyte in lymph node, and this is also reflect why the mycetoma transport by lymph node, because if the Langerhans is inefficient to clear the conidia from the site of the infections, this is conidia develop into the grains, and the grains develop infection into and then the grains transport by lymph node to the other side of the infection. Environmental related factors, as we reported by Professor Ahmed Hassan Fahal, all mycetoma patients exposure to sunlight because their job in the rural area. It is known that the UV radiations present in cell light suppress the cell-mediated immunity. The target of UV is the keratinocyte and Langerhans. The UV radiations cause morphological and functional changes, in particular Langerhans cells. The cells decrease in the number. Then the Langerhans numerical reductions in numbers in the epidermis of mycetoma patients. This is described in 1998. What is the evidence of this? UV ultra radiations act as a keratinocyte. A keratinocyte produce two cytokines. Firstly, we reduce TNF alpha. TNF alpha act as pro-inflammatory cytokines. TNF alpha it is inflammatory to control the inflammations when it is reduced in appropriate amount, but when reduced in excessive amount, it is cause tissue damage. In this case, tissue damage enhance the production of IL-10. IL-10 it is tumor necrosis factor alpha inhibition cytokines, which we reduce by Langerhans cells. Then Langerhans cells presenting antigen to T helper lymphocyte, and this is reflect why the immune response to mycetoma infections T helper 2 antibody production immunity. The end result of this fibrosis production in mycetoma patients. We hypothesize that the functional polymorphism in these genes, mainly interleukin 10, maybe has susceptibility to mycetoma infections. Then we need to test the possible association between polymorphism in IL-10 and mycetoma. As Dr. Ihab mentions, IL-10 is cytokines, synthesis inhibitory factors, inhibition to tumor necrosis factor alpha, inhibition to interferon gamma, play essential role in the presence of intracellular pathogen, modulate both adaptive and innate immunity, secreted mainly by macrophage and dendritic cells. This study is prospective cross-sectional study carried out in Mycetoma Research Center and Erasmus Medical Centers. This is a study include 155 patients coming from the attending Mycetoma Research Center, Soba Hospital University, and 215 match control. Personal data was obtained from each patient, which include the age, sex, size of the duration of the disease, size of the lesions. Then all patients on control is screening for infectious disease like HIV, hepatitis B, syphilis, or hepatitis C. Then genotype for SNPs by PCR and R11B method take as carry out in Erasmus Medical Center. Informed consent was taken from each participant in these studies, careful and clinical through clinical interview by standard questionnaires, and general and specific investigations was carried out to each patient to confirm these patients mycetoma patients, which include X-ray, ultrasound, fine needle spirate, biopsy for histopathology and culture. Some biopsy was taken from patients. Data analysis mainly by chi-square test to confirm that all the frequency of SNPs it is deviated from hard-to-unitary equilibrium. This is test considered as significant when the p-value is less than 0.05. This is the profile of the patients in this study, which are most of them are men, student by occupations. Most of them has no history, family history of mycetoma. And this is the characteristic of control group. Okay, this is the genotype of SNPs, which appear homozygote or heterozygote for IL-10. And this is the genotype frequency for mycetoma patients compared with control. And we observe that all the patients on control were in hard-to-unitary equilibrium. And this is the allele frequency for mycetoma patients. And we observe here for leukin 10, interleukin 10 minus 819, the p-value of association, it is more than 0.05. That means there is association between this gene or this allele and mycetoma infection. Before we found this association, we measured the interleukin 10 in the serum of mycetoma patients and found high level of interleukin 10 in mycetoma serum. Then we take biopsy from 10 patients to detect the presence of fibrosis in the lesions, and we found collagenous fibers surrounded by the grains of mycetoma, and found the mycetoma take the color of Manson Fontana. That means the grains of mycetoma contain protein-like collagen. When returned back to the future to the studies, found that the collagenic act as chemotag for the neutrophils. And this is explain why the neutrophils contact to the grains of the mycetoma. Conclusion, polymorphism in IL-10 gene may affect susceptibility of mycetoma, increase the risk of developing of the disease. Polymorphism of IL-10 gene may be valuable marker to predict the risk for development of mycetoma. It is more useful to think of mycetoma in the term of biological relationships rather than the term of anatomic forms of growth and replication. In the last, I would like to thank my supervisor, Wendy, and all members in the medical department of microbiology and infectious disease in Erasmus Medical Centers. And I would like to thank all members in mycetoma research centers. I would like to thank Mohamed Noor to do the analysis of this study, statistical analysis of this study. I would like to thank Prof. Ahmed Hassan Fahal, and would like to thank my friends Isra Nur Rahman to help me and support me during this study. Thank you.
Thank you, Ms. Najwa. I'm sorry I did not introduce Ms. Najwa properly. As far as I know, she is working with the Nile College at the Medical Laboratory Sciences program, and she's doing her PhD on the mycetoma patients' immunological reactions. Now I open the discussions for the group. If someone wants to ask the two speakers on the immunity to mycetoma and their work in this field, please. Can you introduce yourself, please? هنا الصف الثاني.
Thank you, Dr. Ihab and Najwa, for this elegant, informative talks. In fact, I have two comments or two questions. During your study, you have a very nice picnic journey in varieties of immune interaction against mycetoma infection. Did you ever test the role of toll-like receptors in this, as a part of innate immunity, or even if you heard about it? And then I want to ask about the side concerning the part of the practical using of phycol high-back methods, because there is many comments in this technique. Did you face any problem with this technique? Because I introduced it just recently to my lab. Did you face any problem with this technique? Because also there is a new technique for separation lymphocytes. Thanks.
Okay, thank you. Concerning your first questions about toll-like receptors in macrophages, this is still now not done. Especially that the dendritic cells, the macrophage of the skin, and it is very important in decoding the antigens and presenting the antigen for T lymphocytes. But till now, no data about that. But I think it is very important for this work, because here, as we know, the cytokines interferon gamma is a promoted and inducted the action of macrophages and dendritic cells. And still in the cytokine in the lesions of histopathology lesions, also we saw the macrophages are stacking and couldn't to eradicate these antigens. So I think that the toll-like receptor is very important for more study. No, for mycetoma, no. For mycetoma, no. If for EU mycetoma, I think, for not for Najwa, if you want.
For toll-like receptors, when we compare mycetoma infections with tuberculosis infections, mycetoma it is different, because the granuloma in mycetoma mainly controlled by neutrophils, and in tuberculosis by macrophage and lymphocytes. Here, neutrophils act as pro-inflammatory cytokines. No specific reactions in mycetoma. We cannot say this is granuloma in mycetoma. As a result, the actions of toll-like receptors have no roles.
Sorry for interruption.
No.
You cannot ignore their role because they are part of innate immunity. So I think broadly you can face the role, or you can recognize it in literature, recognize the role of this important part of innate immunity.
Toll-like receptors act as other fungus like Aspergillus and Candida, because have two forms, conidia, then shift into